morning. So the first lecture regarding cardiac imaging pitfalls will be about CT. My name is Gorka Bastarrica. I'm originally from Spain. Now I work in Canada, in Toronto, the Sunnybrook Health Science Center. So I have nothing to disclose regarding this lecture. The learning objectives of our session now would be to become familiar with approaches to reduce false inaccuracies and misinterpretation when assessing coronary vasculature. We will learn about practical aspects of post-processing, reading, and reporting non-invasive cardiac CT exams, and we will learn how to improve reading of results by recognizing causes for various artifacts in cardiac CT. I've divided the lecture in anatomy. We will see some recommendations or appropriateness criteria when we should do these studies. Then we will do something about artifacts, and finally how we read or what are the critical aspects when reporting these studies. So we will start with the anatomy, and these are some easy slides that I want to share with you. It will be 10 cases total. This is the first case. It's regarding the anatomy. I'm just asking an easy question here. It's which of the following is not a coronary anomaly? So you have number 1, 2, 3, 4, and the 5 is all our coronary anomalies. So please, you can vote. So you said number 3, so C, and exactly the answer was that one. This is a common mistake that some people do at the very beginning when we start reading cardiac CT, because we suddenly see an artery which is more prominent for any reason in that specific patient, and we tend to think that that could be an anomaly that you just read in the book. Remember that this is the normal anatomy. Here we have the left main. The left main is bifurcated into the circumflex and the LAD, and then we have the RCA. That's normal. And when we look at the RCA, remember that this artery here is the second branch. Usually, we will have first a conus branch, which is this artery, which goes directly into the conus, into the infundibulum of the right ventricle. There we have this second artery, which is a sinoatrial nodal artery. And this is a normal artery. It happens in 60% of the cases. It's coming from the right, and it will go to the sinoatrial node. When it comes from the left, usually we will see it around this area, and it will be in 40% of the cases. After the conus branch and the sinoatrial nodal artery, we will find these branches here, which are acute marginal branches. So this is not an anomaly. This is an anomaly. We see a right coronary artery here. We see the right coronary cusp, and then from the right sinus of Valsalva, we will see this artery, which is a circumflex artery, and see how different it is. In the previous one, it will stop in this area. It was thin. However, this one will come from the aorta, will have a retroaortic course, and it will follow its course along the atrioventricular groove. So see how the difference is that you can follow the entire course of the vessel behind the aorta. And usually when we divide coronary anomalies, we will divide them according to its course and origin, whether it's retroaortic, this one, or this one. For example, this is a single coronary artery, and it's an RCA, and everything is coming from the RCA. Retroaortic course. And then we have another one, which is interatrial course. And this is clinically relevant. The first ones are anomalies that will not cause ischemia, whether these ones, the interatrial course, as you know, they can cause ischemia because of differences in pressures between the left ventricle, the aorta, the right ventricle, the outflow tract. There could be squeezing in exercise, for example, and there could be an ischemia. And here you can see two different options. You can find the left coronary artery arising from the right sinus of Valsalva, or you can find the right coronary artery arising from the left sinus of Valsalva. And this is important to recognize. These are anomalies that course interarterially, as said, between the pulmonary artery of the outflow valve and the aorta. Not necessarily it's always as sharp as that. Here you can find exactly the same anomaly, but they are not. It's not coming exactly from the sinus of Valsalva. It's coming a little bit more cranial to the sinus of Valsalva, as you can see here. But again, you can imagine that when there is exercise, when there is high pressures in this area and high pressures in this area, there could be a squeezing of this vessel. Not always the anomalous coronary vessel would be with a malignant origin. As said, you can find it retroaortic curves, or you can find prepulmonary or prepulmonic curves, like in this case. You see that the left coronary artery is arising from the right sinus of Valsalva, and it will go over the pulmonary artery itself, as you can see here. Please note that CT is very good for coronary anomalies, and it could be the first imaging modality because of the spatial relationship and the anatomical relationship easily depicted. So in a cath, you can see this anomaly. You may have, you could ask, is it going through interarterially? Where is it going? Which is the course, and here in CT, you nicely depict that this is not the malignant course of the vessel. So this is a left coronary artery again, arising from the right coronary sinus. Remember that when we talk about segments, we used to employ this segmentation model. This was published in 1975, and this is the 15-segment American Heart Association model. So the right coronary artery is divided in 4 segments, then we have the left main, etc. If you want something more actual, more than that we can use nowadays, you can use this one, which is proposed by the Society of Cardiac Computed Tomography. Instead of 15 segments, the coronary vasculature is divided in 18 segments, and this is according to CT imaging modality. So you have to imagine that the heart itself is squeezed, and all the arteries will be displayed in a single plane. And this is, instead of 15 segments, you will get 18 segments, where we have the ramus intermedius is named separately, and then the posterior descending arteries, if it's coming from the left, it's named separately, and then we have the left posterior arterial branch also separately. So it will be 18 segments instead of the 15 segments. So this is a mistake that we make regarding the coronary anatomy. This is another mistake we can make when we are reading cardiac anatomy. And this is the second question I'm asking to you. This thing that is pointing the arrow, it's a right atrial thrombus, it's a prominent crista terminalis, it's a prominent intubation valve, or is it a moderator band? When we see a CT, we will find this lesion. What is this? You can vote, please. So this is, most of the people call this prominent crista terminalis. Remember that we're talking about pitfalls in cardiac imaging, and I will show you this, which is a real pitfall, and we shouldn't make this mistake. In fact, this is a case that was asked by a senior doctor to me, and he asked me, I'm reading this, I'm not sure, what is it? Is it something normal? No. The first thing, always look at the entire case. I'm sorry, you could find that this individual had a portacat, so had a central catheter, and this patient had this area here. So this was a thrombus. So again, that's the place for the crista terminalis. So see what happened. This was what I was showing to you. This was what the patient had 4 months before. So this is the crista terminalis, and this is the atrial thrombus. But see how the patient had a pulmonary embolism there. So easily, the first thing that you can do is, if you don't know whether that's real or not, go and look for previous studies. Remember always that that's the place for the crista terminalis. As you said, a crista is a well-defined fibromuscular ridge by the junction of the sinus venosus and primitive right atrium, and it stands usually along the posterolateral aspect of the right atrial wall. So not infrequently, they will ask you to do a cardiac CT or a cardiac MR because someone saw in the echo, for example, that there was a mass within the right atrium. Then you will do this study and you will say, no, that's the crista terminalis. But you have to remember the other way around. Sometimes you will find a mass. You have to be sure that that's a crista or it's a thrombus. The best thing is to compare, of course, if you have previous studies, or as in this case, follow the artery, follow the axial images up and down, and you will find that, as I showed to you, this patient had previously a pulmonary embolism, which was not treated because it was misdiagnosed, and then the patient developed thrombosis in the tip of the catheter. So the anatomical landmarks, remember this, for the right atrium is usually this one. When we see crista terminalis, we'll say that's a morphologically right atrium. If I see the pulmonary veins going into an atrium, this would be the left atrium. If I look at the appendages, see how different they are. This is the right-sided appendage, broad-based. This is the left-sided appendage, more tubular, more trabeculated with the pectinate muscles, as you can see. Regarding the ventricles, the anatomical landmarks are for the right ventricle. You will look for this structure here, which is a muscular band that goes from the lateral wall to the septum, and it's called the moderator band. In the left ventricle itself, we don't have any mark, any landmark, but usually it's a ventricle which is thicker at the base and then thins out as it goes to the apex. So if we want to say this is a morphologically right ventricle or left ventricle, particularly when we're dealing with congenital heart disease, well, we should look at this at the moderator band. And once you recognize a moderator band, like in here, you have to look at the artery that's going out of that ventricle. And if it's the aorta, like this one, this is the transposition of the great vessels. So anatomical landmarks for the ventricle would be the moderator band on the right. On the left, compacted myocardium. If you are still not sure whether this is a morphologically right or left, see the movie, see if there is contraction. And if there is contraction of the outflow tract, that means that there is muscle. And if there is muscle in the outflow tract, that's the morphologically right ventricle. Whereas on the left, there is a mitro-aortic fibrous continuity of the annulus, so you won't find any contraction in that area. So always look at the outflow. If there's contraction, that's morphologically right ventricle. After these two initial imaging cases regarding the anatomy, let's move to the indications of cardiac CT. Let's see what can happen to us in our daily practice. And we know that the standard, the reference standard, when we are trying to assess whether there is significant coronary artery disease, yes, no, and its significance, that is the conventional coronary angiography. However, when we're dealing with daily practice, we see that sometimes this is not the real gold standard, and that CT is a good gold standard for that. And this, I think that it happens in all of these except in one. So which one of these do you think that coronary CT angiography may be preferred to assess instead of the coronary invasive, regular coronary invasive angiography? Do you think that it's better for coronary artery stenosis, for coronary anomalies, for patency of bypass grafts, for patency of stents, or 3 and 4? So if you have to tell to the clinician, if you have this case, you should do a CT. What do you think that would be the ideal scenario for that? So coronary stents is what people answered, and I agree with that. Patency of the stents. Coronary angiography, the conventional angiography, is the gold standard for that. Some people also said 3 and 4, bypass and stents. Let's look at these images. Again, diagnostic imaging usually is done by conventional coronary angiography, and it's very difficult to beat this imaging modality because of its temporal and because of its spatial resolution. So we are not there yet. We will see it later. However, if we want to assess for an ostial stenosis, CT is very frequently better than the conventional coronary angiography. See this case, for example, when you do a conventional angiography, you put the catheter and you see the RCA perfectly well. However, with CT, you can see that there is an ostial stenosis. So what can happen is that the person who's doing the cath, he can put the catheter too far away into the ostium, so he can miss easily a stenosis at the origin. This is one thing. And the second thing is that if we see a stenosis, we have to say it, because sometimes they can occlude the vessel if it's too tight, that's stenosis, and they put a catheter, they can occlude temporarily the vessel. So when we report this, first, look at the ostium, because they will miss it, and they can miss the lesions. Second, be aware of what can happen, and you have to tell the cath lab person that there is a significant stenosis. So this wasn't a problem, as I said. This is another interesting case. Exactly this is what happened in this case. The person who did the angiography, he put the catheter too far, and suddenly there were some arrhythmias in the individual, so he just retrieved it and said there may be a stenosis. So they ordered for a CT just to confirm whether it was or not. And of course, when there is such a critical question, if an artifact has to happen, it has to happen in that specific place. So this was a tricky case for us. You can see a stair-step artifact. However, we will still be able to demonstrate a tight stenosis at the origin and post-stenotic dilatation that you nicely see here in this volume rendered image. So remember, always look at the ostium, because we are better than the conventional angiography in that area. Regarding the coronary anomalies, we've seen a case. I've shown to you a case. I will show you this one too. This was a coronary fistula and was nicely depicted in echo. They saw it perfectly well. So they say, okay, let's look at it more carefully. We'll do an angiography. And they confirmed the fistula. But they couldn't find the RCA. It was a nice fistula of the left anterior descending artery, but they couldn't find the RCA. And they couldn't find it because it had an anomalous origin from the left sinus of Valsalva, as you can see, with an interatrial course. So again, nicely depicted with CT, a coronary anomaly that they cannot find. Some people said that conventional angiography may be preferred to assess the bypasses over the CT. However, in real life, you will see that you will do many studies to assess bypass graft patencies. Why? First, if the person who is doing the angiogram doesn't know exactly what the bypasses are, it will be difficult to cannulate all of them. If he doesn't know well the history of the patient, how many bypasses he may have, it will be difficult to cannulate all of them. However, with CT, we can easily see how many grafts the patient may have. This patient, for example, he had 3 grafts. He had the lima to the LID, which was patent. He had an obtuse saphenous vein graft to the obtuse marginal branch, and then he had another graft to the RCA. And we see that all of them are patent except the SVG graft to the RCA, which is occluded. And here we see this kind of nipple at the ascending aorta. And one of them had a significant stenosis at the origin. So see how frequently we can find easily how many grafts the patient has and if these grafts are patent or not. A different story, though, is when we try to assess the the native coronary vasculature. These vessels are usually diseased, that's why the patient had a bypass, of course, and there is flow competence, so sometimes these vessels are very small. So when we read figures regarding the accuracy of CT in assessing bypasses, you will always find sensitivities around 98%, specificities around almost 97, 98%. However, most of these studies are not evaluating the native coronary vasculature. So to assess the bypass grafts, and that's a clear indication according to the appropriateness criteria, we should do a CT. However, you will find many difficulties when we try to assess the native coronary vasculature. When we're dealing with the stents, though, that's a different story. The stents, you know that they're made of metal, and all of them can be accurately assessed. When you look at sensitivity and specificity values, always look at if the stents were included or there were excluded stents. If not accessible stents were excluded from the analysis, you will find 90, 91. But if they are included, like in this meta-analysis, you will find the sensitivity of sentinel specificity of 81. And why is it? Because not all stents are accessible. In fact, when we look at the appropriateness criteria, they will tell you that the stent has to have at least 3.5 millimeter diameter. So if you want to assess a stent still, the luminal patency still, the gold standard will be the regular coronary angiography. Let's continue with the stents. I say that it is true that 1, almost all stents are accessible. 2, MIP or MIP reconstructions are helpful in assessing patency. 3, soft tissue reconstruction algorithms are preferred. 4, the presence of contrast distal to the stent reflects that the stent is patent. Or 5, none of the above. What do you think that is true of these 5 statements? So you said almost none of the above. I agree with you. None of the above, it's true, and we will see it why. So you see, this is a very, very classic paper where you can find that's the ideal scenario where you should be able to evaluate a stent with CT and see how different all stents are. Here you see how at some stents you won't be able to assess the patency, never. And sometimes you will be able to assess the patency of the stent quite nicely. So regarding the metal, what it's made of, the stent, you will be able to assess. So not stents are all accessible. And in the past, we used to say that about 50% of the stents only will be accessible. Now the figure is number, but again, not all stents are accessible. Second, MIP reconstructions are not good to assess the stent patency. Why is it? Because you know what MIP does. It just shows you in one image all the high-density pixel values. So if the stent has a high density, you won't, if you just do a thick MIP, the only thing that you would do is just enhance the stent struts, but you won't be able to see what's happening inside the stent, like in this area or in this area. So don't use MIP images to read stents. Volume rendered images, which people like to do, they are not good to assess stents neither. They are good to show where the stent is in case that the surgeon wants to revascularize that individual. They are good for that. However, they are not good to assess the stent patency if you can play with the different settings and show the lumen nicely. So they are good to show where the stent is, but again, if you want to assess the stent, use regular NPR or regular axial images, not MIP or advanced volume reconstruction post-processing. Regarding the stent, always, we want a little bit of noise in the image. That's why soft tissue kernels like this one are not the preferable kernels or reconstruction algorithms to assess the stent patency. We want a little bit of noise so we can differentiate it nicely what is metal from the hyperplasia or the intimal hyperplasia, as you can see here. So always ask for a specific reconstruction when you want to assess stents. Here you have another interesting case where here I wasn't able to see anything, whereas here I nicely see intimal hyperplasia. So always use specific algorithms with a little bit of noise. There's a balance between noise and quality. These algorithms have a little bit more noise than usual, and they are very helpful to assess the lumen. Again, MIP images are not good to assess the stents, but are very good to assess the distal vasculature. Here, some people at the beginning, particularly when we're dealing with electron beam CT or 4-row multi-detector CT, there was always a conclusion in a paper saying that if you see that the vessel is patent distally, even if you cannot assess the stent, this means very likely that that stent is patent. However, we know that that is not true, because what can happen is that there is retrograde filling of the vessel due to collateral vessels. So here I will show you nicely that you see in the MIP image that I'm showing that if they want to, for some reason, revascularize this patient, again, surgically, the vessel distally will be patent. But the stent itself is completely occluded, and it's occluded even more proximal to the stent. So not necessarily contrast distal to the stent means that that stent is patent. Be careful with that. Always try to look inside the stent or proximal or distal to that stent. Let's move to another one. Let's move to what it looks like, but it is not. Let's look for artifacts now. Let's see how we can deal with common artifacts in regular practice. So this is the first case I'm showing to you. This was definitely not the best case that you could do. He was 79-year-old. He had COPD, diabetes, hypertension, hyperlipidemia. He had a prior myocardial infarction and frequent extrasystolia. So when I saw that request, I said, I'm not going to do this because this is not a real indication. That's not appropriate a cardiac CT on that individual with all these cardiac risk factors. However, unfortunately, he was a colleague's father, so he asked me, let's do it, because I wouldn't like to cut him. It's not necessary at all. So we did the exam, and as always happens with the recommended people, this is what we got at the beginning. This is what I got when I went back to my office and sat, and I started to read the study. I did an MAP, and this is I said, oh my God, what is this? So what would you do next? What did I do next? I said, this is atrial fibrillation, I cannot do anything else. Or I had to repeat this study and ask the patient to hold his breath because I think there was motion artifact. Did I repeat this study after additional beta blockers because the heart rate was too high? Did I review the source images and change the reconstruction phase? Or did I choose another reconstruction algorithm because I saw there was a lot of calcium and maybe if that could help me with the assessment? What do you think I did? Or what should we do when you go home? What should you do in this kind of cases? You can vote, please. Exactly. Exactly, and this is a very good point. So never desperate when we see a case like this. First of all, go back to the raw data, go to the axial images, and see if this is the appropriate phase or not. Because sometimes the tech, for some reason, doesn't have time or doesn't know how to do that, or for some any other reason. He will just reconstruct the images that were obtained and just will send them over to the PACS. And when you start doing the reconstructions, suddenly you realize that maybe that's not the best phase. And in fact, when we corrected, it was a 60% of the RR interval. When we evaluated the vasculature in another interval, 75%, this is what we found. So the most common artifact, I would say, when we're doing, like when the study has been all very well done, is that if we don't choose the correct phase, be careful with that. The arteries we are able to see the arteries almost, particularly when we're using new generation scanners in many phases, but see how at 75% the RCA, the mid-segment of the RCA cannot be well assessed, whereas if we're dealing with a 45%. So in systole, we can assess it more nicely. So remember that maybe one phase only won't be enough to assess all the coronary vasculature. Remember that. If the heart rate is stable, low, less than 60, probably yes. But if not, always if you can move along different cardiac phases. The artifacts that are more commonly seen on CT are blurring, strake, slap, and step artifacts. These are the most frequent artifacts that you will find. And generally, these are due to limitations of our system regarding the spatial resolution. It's not enough. Temporal resolution is not fast enough acquiring the images. There is too much noise in the image, or the reconstruction algorithm that we chose wasn't the appropriate one. So always, regarding the spatial resolution, remember that we are not too accurate on that. So there will be blooming artifact accentuated because of partial volume effect. I don't have to explain to you what is partial volume effect, but remember that this artifact is very frequent due to the limitations of spatial resolution. Regarding the temporal resolution, if the scanner is not fast enough, it's very easy to find problems regarding arrhythmias, stereostep artifacts, blurriness, etc., if the patient doesn't have a stable and low and very steady heart rate. Regarding the contrast to noise ratio, always, if you can, use strategies to reduce the noise. You've heard a lot about, in this Congress, about iterative reconstruction. You've heard a lot about low KB usage. This is okay. You have to combine everything that you have to get this kind of images which are noisy. So you can do a thick MPR, or you can do MIP images, and this will help you to reduce the noise once the study has been acquired. So always be careful with the noise and the contrast. So if you are using low KB, you will get more signal, you will get more noise. Remember that you can use different strategies to decrease the noise. Remember that, please. I will show you another typical case that happened to me. This was a 40-year-old male with atypical chest pain. And this is the image that I got in the reconstruction, after the reconstruction in the PACS. This is I said significant stenosis of the left main. I said significant stenosis of the proximal LAD, mixed plaque proximal LAD. I said 2 and 3, or I said all of the above. So if you have to vote for one of those options, what do you think that this patient has? So people said all of the above, almost everyone. And exactly this is what happened to me at the beginning. But see, remember, if you see stenosis, you have to confirm it. You have to confirm it, particularly if you have the ability to change phases, confirm the stenosis. If it's real, it has to happen always. If not, look, this is 35%. He had a high heart rate, so I said a systole would be better. In this particular case, I did a retrospective acquisition because of his high heart rate. This is what I found. But again, I have to confirm it in another different phase and see at 70% DLAD what happens. There is a significant stenosis of the left main, as everyone said. Perfect, but look at the LAD. This lesion here was an artifact. So always when we look at the artery and we want to say there is a stenosis, if we can, we are doing with padding, we are doing retrospective gating, whatever we're doing, try to change the phase. And with that, you will avoid artifacts, and in this particular case. So a segment of a stenosis, remember always this, should be visible on 2 different phases. I would say in all different phases that you can find. So if it's not like that, it won't be probably a stenosis. Remember that there are many artifacts on CT. This is critical. Stenosis has to be present on more than one phase. Remember that we usually reconstruct one image, but if we can, we have to move. And the RCA and the circumflex are mostly well seen on systole, most frequently, the LAD in diastole. If the heart rate is low, less than 60 beats per minute, everything in diastole will be well assessed. Whereas if the heart rate is higher, probably we will have to move to systole. Remember this, please. Another common mistake that we make is this one. You are reading the study with a fellow, and the fellow will tell you, okay, this is the post-processing images that I got. And he will put them on the screen for you, and this is what you will find. This is number 1, 2, 3, and 4. And one of them is not a real coronary stenosis. Which one of those do you think it's not a real stenosis? Number 1, and I agree with number 1, and I will show you why. And the message I want you to take home is this one. Stenosis is associated with a plaque. So if I don't see a plaque, I'm very unlikely this would be a stenosis. Remember that that's an atherosclerosis process. There will be a plaque, there will be narrowing. If I cannot find a plaque, that won't be stenosis. Remember that usually what we do is visual assessment of the plaque. When we say this is calcified, this is partially calcified, or this is non-calcified. And see, even if this area here, it's a positive remodeling. So even if this looks like an artifact, always the axial the cross-sectional image will show to me that that was a real stenosis because I can see the plaque. And number 3 was easy. Plaque assessment usually is done visually, but remember that there are software tools, more and more sophisticated, that can help you to assess the morphology and composition of that plaque. You can theoretically do it with some post-processing tools. Again, this is the case. Looks like it could be an artifact, but again, there is a plaque. There is a positive remodeling. This one also, we do a curve planar reformat, and we always look at the images interactively. So one image for me is not enough. I want to see the entire MPR. Here I see it very nicely, and again, there is a plaque. I can see it nicely. This one, however, that's a common pitfall that we make. We can see the axial, the curve planar reformat very nicely. We can see nicely the area there, and the fellow we can tell that that's a soft plaque causing significant stenosis of the LAD. The first thing that we will do is just rotate the image, and if you find exactly this, that's a third-step artifact. So see, always rotate the image. Don't rely only on one image. Do interactive review. See yourself the image, rotate, do whatever you want, and if you don't see a plaque, like in this area, this is an exaggerated example, but this is what happens in real life, this is third-step artifact. It's not a real stenosis. Remember, for the plaques, we want to assess whether it's calcified, non-calcified, or partially calcified. But if we want to assess what plaque has more vulnerability, let's say that, like which is a high-risk plaque, we would say that that's with tiny calcifications, spotty calcifications like this. When we see positive remodeling, this is the vessel is expanded, that's a high-risk plaque. When we see a napkin ring sign, or when we see hypodensities within the plaque. So these are the 4 features for a plaque to say that it could be vulnerable or it's a high-risk plaque on CT. These are the 4 features. Spotty calcifications, positive remodeling, napkin ring sign, or hypodensities within the plaque. Here we have the 8th case. Again, something that happens quite a lot is this case. It's a 56-year-old male with atypical chest pain. What would you do next? Would you repeat this study with nitro when you see this area here? You think that maybe the heart rate wasn't good enough, so you would give additional beta blockers? Would you review the axial images? Or would you call the cardiologist before the cath because you think that there is a significant osteostenosis and you want to avoid this, what we said at the beginning, this blockage of the origin of the vessel? So what do you think that when you see this image you should do? You are reading, remember, you're reading the CT, the cardiac CT. Unfortunately, you have another 25 chest CTs to read that day. And this is the resident comes to you and he will show you this image. Review the axial images. So you know from experience that this is a very frequent issue. And again, always remember to review the axial images because these are the source images. Remember the interactive review, very important. Use every tool you can. If you see an axial partial luminal filling here, and here we can confirm it on the MIP or the curve MPR on the volume render image, this is a real thing. The axial images are very nice to assess the quality or determine the study quality, the most important. MIP and MPR reconstructions are good. MPR are usually used to evaluate short segments. MIP images are nice to review the vasculature long distances, but not very good to assess the luminal stenosis. If there is a soft plaque, MIP will underestimate the degree of stenosis. If there is a calcified plaque, it will overestimate the degree of stenosis. So we won't rely on the MIP images to assess the stenosis, just to look at the vessel ES. Curve planar reformats are very good. are very good if they work well. It will elongate the vessel, it will take the center line points, and it will give you one plane, very nice. However, pseudo-illusions are frequent. In this particular case, this is what we saw. Always we go to the axial images. And the axial images show that the origin is very patent. What's happening there? The center line, it's not well depicted, so you just change the points, and you will find nicely that the point may have jumped to this area. You correct that point, and you don't see any stenosis there. So remember always to look at the axial images when you do post-processing. Regarding the reporting, two cases that I want to show to you. One is the following. First of all, if you want to report a case, you don't know how to do that, these are the two guidelines that you can follow. This is the Society of Cardiac Tomography. This is the American College of Radiology. If you want a template, this one has a template. If you want more details, you can find them here. So these are the two papers that I will recommend to you. Regarding the stenosis, you would grade this lesion as less than 25% stenosis, 25 to 49% stenosis, 50 to 69% stenosis, 70 to 99% stenosis, or is it a coronary occlusion? What do you think it is? So 50 to 69% stenosis. I don't want to, we could argue with this, because it looks like it's a significant stenosis. The take-home point here is that I call this 25 to 49% stenosis. I will tell you why. The important point here is that CT tends to overestimate the degree of stenosis. And why is it? Because we see the wall and we see the lumen, we see both. So our eye goes and does the calculation regarding the entire wall against the entire lumen, and this is how we try to do that. If we want to be accurate, we want to do exactly what the cath people are doing, we should just look at the lumen and see whether there is luminal narrowing and compare lumen to lumen. We shouldn't compare the entire wall against the lumen, or no. Just take the lumen, proximal or distal, so a normal segment, proximal or distal, and measure the lumen. And the luminal narrowing is what we have to do. We usually do visual grading. Visual because we don't have enough spatial resolution. See, the best we can get nowadays is around 0.5 millimeter. The best, that's the best we can get. The spatial resolution of a coronary CT, conventional coronary angiography, though, is 0.16. So in the best case scenario, we are in a threefold worse spatial resolution. So again, remember that we may not be accurate. We may not be accurate even comparing lumen to lumen. So what we did is always try to look at all the NPR images, and I compared the lumen, and it gave me 49%. So I said around 50% stenosis. The cardiologist who saw the image, he said, no way, this is more than 50, so I will do a stress test. This is what he did. We did a MR perfusion, and it was normal. So there was no significant stenosis. Doesn't matter. Sometimes we will go overestimate, sometimes we will underestimate. That's why we should have like a proper way of looking at the images. Always do lumen to lumen. If you have doubt, remember that we overestimate, so you can do a little bit less than what you expect. Should we do quantitative assessments? Should we do manual measurements? Should we do, what should we do? Remember that the spatial resolution is not good enough. So if you read some papers, they will tell you that if you quantify the stenosis on CT, it will be very similar to what you would get in coronary angiography, but this has to be a very specific case, very nice, well-depicted plaque. So this statement here is not necessarily always correct. Manual stenosis is more accurate than automatic measurements. This is very likely correct. So do manual measurements, always measure. And remember, we cannot give a exact number because our spatial resolution, so we will do degrees of stenosis. And this is according to the appropriateness criteria, or how we should do the studies. This is how we should grade the stenosis. We should say that's a normal, minimal, mild, moderate to severe. This usually It's not very much liked by cardiologists. They will prefer numbers. For us, anatomically, more than 50% is what we would consider significant stenosis. We should say it's more than 50, less than 50, more than 50%, less than 50% luminal narrowing. But cardiologists sometimes want a little bit more. If they want a little bit more, go 50 to 69% stenosis, more than 70% stenosis. Always percentages because of the limitations of the spatial resolution. And this is the last case, and this is another take-home point that I think is very important. He's a 59-year-old male. He has atypical chest pain. And now we will do everything that we've seen now. Your most important diagnosis would be, in this particular case, more valuable diagnosis for the clinical aspect point of view would be, he has patent coronary arteries, so we have ruled out disease, so that's the most important thing I can tell about this CT study. No, he has a circumflex anomaly. There is a myocardial bridging of the LAD, superficial bridge. He has a radius of thrombus, or none of the above. So if you see this image, what would be your most important diagnosis that you would make in this particular patient? You can vote, please. So myocardial bridging of the LAD, and the rest said none of the above. So this is something that happens frequently. I would say none of the above, and I will tell you why. This is something that happens very frequently. You know that we don't have spatial resolution. It's not good. We try to improve it. For that, we do a small field of view, so all the pixels on the 512 by 512 matrix have the most important information. So yes, this is what we do. We try to type the image. What happens, though? We can miss something important. Remember that the CT of the heart is a CT of the chest. So see, we can miss easily this thing, and this was the lung cancer. So always remember that when we read the CT of the heart, we are doing a CT of the chest. So do a full field of view reconstruction, look at the extracardiac findings. So some of them will be clinically important. They will need therapy. Others will need workup, pulmonary nodules, follow-up, for example. Others won't need anything. And remember also that we can find etiologies that are causing the chest pain, and the clinician may suspect coronary disease, but we can easily find, for example, a hiatus hernia, which is causing the symptoms. So always look at the extracardiac findings. So the 10 take-home points with each case are the following. Remember the coronary anomalies. Remember interatrial retroaortic curves. Remember the cardiac anatomy and variance. Remember the crista terminalis. Remember that structure, important. Invasive angiography is not necessarily always the gold standard. Remember that the coronary stents are difficult to assess, so probably will require additional effort from us. Before giving up, check all available images, all the reconstructions you can have. A true stenosis has to be always present in all the phases. Remember that. That's a nice case. A true stenosis is caused by a plaque. If you don't see a plaque, that won't be a stenosis. Be careful when using post-processing tools, and particularly volume-rendered images and curved planar reformats. Be careful with them. CT tends to overestimate the degree of coronary stenosis, as in the case that we saw. And always, as radiologists, remember that we have to look for extracardiac findings. Thank you very much.